Of Donald Trump and a Republican-controlled House and Senate have left the future of the U.S. healthcare system in question. Given the Republican Party's recent failed attempt to repeal and replace Obamacare, as well as their upcoming attempt, there has been significant conversation regarding the most effective way to move forward, with many on the left, most notably Bernie Sanders, calling for a single-payer system. Tonight, we have Dr. David Himmelstein here to present an argument as to why a single-payer system is the best way to move forward from the Affordable Care Act. Dr. Himmelstein is co-founder of Physicians for a National Health Program. He's also currently a professor at CUNY School of Public Health, adjunct clinical professor at Albert Einstein College of Medicine, and a lecturer in medicine at Harvard Medical School. He has also written extensively on various issues in the field, most notably creating a report that led to EMTALA, an act that ended the practice of patient dumping. It is my honor to welcome Dr. Himmelstein here today.
I was worried about how I'm going to be introduced. Years ago, Eleanor Roosevelt was speaking in Maine, and the woman who was going to introduce her said, "How do you want to be introduced?" And she said, "Please don't make it one of those long, flowery introductions, make it brief." So the woman got up and said, "This is Eleanor Roosevelt, and the less said about her, the better." So I have no financial conflicts of interest, and you've heard potentially other conflicts. Now, this recent quote from the Pope actually in some ways encapsulates my view of where we stand and what our problems are in healthcare as situated in the broader society. So he said, "Just as the commandment, 'Thou shalt not kill,' sets a clear limit in order to safeguard the value of human life, today we also have to say, 'Thou shalt not,' to an economy of exclusion and inequality. Such an economy kills." And in healthcare, that economy as expressed actually literally kills. I don't know if we need the lights on. I want to see you. Can we put the lights on? That way you can go to sleep and I don't even know. So this is the mean family income of each fifth of the population, starting from poorest on the bottom to wealthiest on the top. And over the last 40-some years, there's been a huge dissociation of wealthy people from the rest of our society. The blue line at the top is the line representing the wealthiest 20% of our population. And that element has seen enormous income gains. And if you disaggregate that even further into the top 5% and the top 1% and the top 1/10 of 1%, the separation becomes ever more extreme. We're a society that, in essence, is falling apart. One reflection of that, in some respects, is that we keep an enormous number of people in prisons in our society. So one aspect of maintaining inequality is that we put huge numbers in jail as a consequence. This recent disturbing data about the incomes of minority college graduates, that while non-Hispanic whites over the period 1992 to 2013 saw a somewhat substantial increase in their average incomes, blacks and Hispanics actually fell in their incomes. This is among folks with college graduates. So again, another indicator of the coming apart of our society. And job discrimination is persisting in our country. This is a randomized experimental study where they sent curriculum vitae to jobs and saw who got called back for a job. And on the left you see black applicants, and they had four versions of the resumes for each applicant. One was a minority resume that used a typically minority name and also had experiences in college that indicated that the person was a minority. So for instance, leadership in the Black Students Organization. So the extreme left is the callback rate for people who had both of those characteristics on their resume. And the next, the 13%, is those who whitened the first name, left the indicator of participation in African American student activities on the resume. The third is leaving the is whitening the experience, but not the first name. And the fourth is whitening both the first name and the experiences listed on the resume, so that there's a very steep gradient, about 2.5 times the callback rate for actual interviews, depending on what's on the resume. So for Asians, not as extreme, but also considerable evidence of discrimination. We're a society that remains deeply troubled along many lines. And among non-Hispanic whites, we've seen disturbing trends as well. So overall, among all persons between 45 and 54 years of age, among non-Hispanic whites, the yellow bar there was a 33 per 100,000 increase in the death rate between 1999 and 2013. So an almost unprecedented increase in the death rate. But if you disaggregate that, the entire increase was among poorly educated non-Hispanic whites, a very sharp increase in death rates. Among those with some college, essentially a stable death rate, and among the well-educated, best educated group, a substantial fall in death rate. So again, separation within our society on many lines. And just to make the point that although non-Hispanic whites of poor educational attainment have seen the sharpest recent rises other than Native Americans in death rates, the death rates for African Americans remain disturbingly higher than any others. Now, this is actually trends for the society as a whole. On your left is the remaining life expectancy at age 50 for people who were turned 50 in 1980. These are projections based on current cross-sectional death rates by age. But you see that the poorest group, which is the left-hand bar in kind of orange there, would expect to live about 32 years on average after they turn 50. And the wealthiest group, the extreme right, would expect to live about 36 years. So there was about a 2-year difference in life expectancy between rich and poor. I'm sorry, a 4-year difference in life expectancy between rich and poor among those turning 50 in 1980. And the 2010 figures are on your right. And the point there is there's now a 13-year difference in expected remaining life for people who turned 50 in 2010. This is data from the National Academy of Sciences study. So the pulling apart is not just of income, but in health status as well. And we're facing an unprecedented separation that's not repeated in other countries. So this is similar data for Canada. On your left is their 1991 figure. This is remaining life expectancy at age 25. And on your right is the 2006 data. And you see that the differences have actually narrowed during that period in Canada, a period when we had dramatic widening of income-based disparities in the US. Well, we trail most other developed nations in our health statistics. So the US is in yellow in these slides. This is our life expectancy, and on average, Americans live about 3-4, as much as 5 years less than people in other developed nations. Our infant mortality rate is really quite shockingly high for a wealthy nation like ours. Our maternal mortality rate, if anything, even more out of line with other countries. So we're more than twice as high as pretty much any other developed country in our maternal mortality. And this in the context that 2/3 of our health spending in this country is government money. So we're used to thinking of ourselves as having a private health system with private health insurance. And yet 2/3 of the total spent on healthcare in this country comes from the taxpayers in one way or another. Now, I've included in this not just the traditional public spending categories like Medicare and Medicaid and the Veterans Administration healthcare system, but two other large categories. One is public employees. So when the government pays for the health insurance of teachers and President Trump and firemen and the FBI agents. That's actually public money, and that's about 24% of the employer-paid private insurance market is government employees. And the second large category I've included is the tax subsidy for other people's private insurance. So when I get insurance from my job, I don't pay taxes on what my employer spends for that insurance. If they paid me $10,000 worth of income as wages, I would pay about $4,000 in taxes. If they give me $10,000 in health insurance, I pay no taxes on that. And the budget of the United States actually classifies that as a tax expenditure, which is about $300 billion each year. It goes mainly to wealthy people who are in higher income brackets, and is almost as much as the federal government spends on Medicaid, but we notice it much less. It kind of flies under the radar. But with those additional two categories, 2/3 of our health spending is government money in this country. And one of the things that's striking, if I can get there, is, you know, we're an outlier in how much we spend on healthcare. So we spent last year about $10,000 for per capita on healthcare, and the next highest country is Switzerland at about $7,000 per capita. And the point in this slide is the yellow is our government expenditures on healthcare, and we spend more in government money on healthcare than any other nation except Switzerland spends on its entire healthcare system, public and private money. So national health insurance is something we're already paying for, but we're not getting it in this country. We're spending clearly enough to give every American coverage as the people in other countries get. Now, our costs are not so high because we are avid users of medical care. Americans don't visit the doctor all that often. You see about 4 doctor visits per person in the country each year. And other countries, I mean, Canada is nearly twice as many visits to the doctor as we do. And we don't spend all that much time in the hospital. Here's the days per person per year of hospital care in our country. And you see we're on the low end worldwide of wealthy nations. So it's not that Americans get enormous amounts of care. What we do get is enormous amounts of bureaucratic cost. So here's our health insurance overhead in this country as compared to others. Every man, woman, and child in the country on average spends about $800 for health company overhead, health insurance companies overhead. That's not premiums. That's the share of premiums that stays with the health insurance company. Now, part of that goes to these folks. So Mike Neerdorf made $20 million in 2015 as the CEO of his company. But frankly, most of the employees of insurance companies are not high rollers. They're mostly low-paid clerical personnel. There are about 1 million people doing useless clerical work in our healthcare system, which is basically the cost of enforcing inequality and extracting profit from our healthcare system. In effect, we have a healthcare system which relies on rationing. So about 1/3 of Americans are inadequately insured, and I'll get back to that in just a minute. They're often denied care, and they're sicker and die younger because of it. When I was first at Harvard, I actually showed this slide, and my department chair said, you're misusing the term rationing, because the dictionary defines rationing as an egalitarian distribution of a scarce resource. And we don't distribute medical care in an egalitarian manner, and it's not scarce. We actually have enough hospitals and doctors and medical equipment to give superb care to every American for what we're now spending. And yet we do large amounts of unnecessary care, even harmful care, while we're denying many people the care that they need. It takes a lot of work to keep sick patients away from idle doctors and empty hospital beds. The blue in this slide is the number of administrative personnel working in healthcare delivery. So this is hospitals and the like. And the yellow is the number of doctors. And the fastest growing component of our healthcare system is bureaucracy. Now, we also have other elements of our healthcare system whose costs are growing rapidly. This is the expenditures for the average patient for insulin over the 7 years between 2006 and 2013. Same drug. And yet we have drug companies essentially using their monopoly power, the patents they hold over insulin, to say your money or your life. So we need a different system for drug procurement. Many other countries have such systems where they bargain with drug companies over prices and enforce price controls, and they pay about half what we do for drugs on average. And our drug companies clearly have a lot of room to give on prices, so the red bars here are the average profits of the drug companies in the US, and the yellow are the average of the Fortune 500. Now one could say, well, drug companies should make a reasonable profit, but should they year after year after year make 3 times the average of the Fortune 500 because they have a product that we cannot refuse to buy? They have a monopoly on life and death. Well, we've made progress over the last few years. This is the number of uninsured in the US, and you see the sharp drop with the implementation of the Affordable Care Act in 2014. We went from about 50 million uninsured to 28 million uninsured. But 28 million uninsured is still enormously more than any other nation that we'd want to compare ourselves to. And even if every state had accepted the Medicaid expansion that was part of the original law and that the Supreme Court ruled states could refuse, and 19 states have refused, we would still have about 22 or 23 million uninsured according to the Congressional Budget Office. So yes, we've made progress, but we still have major problems. And here's some estimates of how many people die each year for lack of health insurance. So colleagues and I at Harvard did a study following people for 16 years. People who were uninsured at the outset of those 16 years, adjusting for their other differences with people who had insurance. About 1 person out of 1,000 dies each year because they don't have insurance. And if you project that to the numbers of uninsured nationwide and in these states, we still have about 28,000 deaths each year from lack of health insurance in the United States. The pattern of who's uninsured remains a pattern that's familiar from the rest of the problems in our society. Minorities much more likely to be uninsured. And we also made progress as measured by people who say, in response to the National Health Insurance, National Health Interview Survey, were you unable to get care that you needed? So 4.5% of Americans say they failed to obtain needed care due to costs within the last year. And that's an improvement from 6.9%, but you see, we're back to where we were in the late 1990s. So again, much more progress needs to be made. Deductibles for people with coverage are rising, so the number of people who have workplace coverage with a deductible more than $1,000. So deductible is what you pay before you get any care. I mean, before you get any insurance to pay for your care. Now more than half of American workers have to take $1,000 out of their pocket before they have insurance. And the policies offered under the Affordable Care Act carried even bigger deductibles. So the average employer paid plan now has about a $1,478 deductible. The silver plans, which is the mid-tier plan sold on the exchanges, has a $3,000 deductible. And the bronze plan, the cheapest plan sold on the Obamacare exchange, has a $5,765 deductible. So before you get care, these are the costs you have to bear. And remember, if you look at what what do people have in the way of savings in our country? So the bottom fifth of our population, the poorest fifth, on average has $1,000 in liquid assets. The next fifth has $4,100. So about 30 to 40% of Americans would be bankrupted by their deductible in the Affordable Care Act plans. And that's actually not the kind of insurance that people need. And we know about medical bankruptcy a fair amount, a series of studies that we did with colleagues at Harvard Law School, a colleague then named Elizabeth Warren, still named Elizabeth Warren, but she's no longer at Harvard Law School. And we surveyed people in bankruptcy courts throughout the United States, and we asked a series of questions about what caused their bankruptcy. And 62% of people said medical bills or illness was a significant cause of their bankruptcy, not the only cause necessarily. Bankruptcy is common. Not as many American women graduate from college as file bankruptcy each year. So there are a lot of bankruptcies. And 62% of them had a medical cause. And this is a piece of the data that got much less attention. And that is, of the people who were medically bankrupt, 60% had private insurance, at least when they first got sick. And many of them had private insurance throughout the illness, but they were bankrupted by their copayments and deductibles. And you see Medicare, Medicaid, 22% were uninsured. That is somewhat higher than the total proportion who were uninsured among the bankruptcy filers. But insurance doesn't provide adequate coverage in our country. Does that matter? Well, it matters. Here's one study where they asked people who were admitted to hospitals with heart attacks and had a delay in coming to the emergency room. And delaying when you go to the emergency room with a heart attack is potentially fatal. The longer your heart goes with a blocked artery, the more likely you are to die and the more likely you are to end up with heart failure. So we say time is muscle, time is heart muscle. And of the people who delayed, people who were uninsured were 38% more likely to delay going to the hospital. Those who were underinsured, people who said they were worried about their medical bills, 21% more likely to delay. So those are the kinds of mechanisms that lead to higher death rates among uninsured people. Now, the recent, or actually not so recent now, the Affordable Care Act in some ways nicely summarized this headline on the cover of The Lancet, the world's second leading medical journal. The healthcare reform process exposes how corporate influence renders the US government incapable of making policy on the basis of evidence and the public interest. Well, what we passed in this country was what I would call the mandate model for reform. So why do I have Richard Nixon's picture on this? It's because Richard Nixon, who was the Republican president in the 70s, who left in disgrace, was the first to propose this model for reform. And the Heritage Foundation, one of the right-wing think tanks in Washington, took up that program and published its version of it in 1989. And Mitt Romney passed it in Massachusetts in 2006 before President Obama passed it in Congress in 2010. And all of these programs had an expanded Medicaid or Medicaid-like program, largely via private insurers for Medicaid. Mostly our managed care companies contract to run the Medicaid program. With subsidies for low income and free care, often for very low income, and buy-in without subsidies for others. A mandate that you have to purchase coverage, either you or your employer, and insurance exchanges. Now, a lot of people have trouble believing that this really was a Republican plan.
President Nixon today pledged his administration to a new national health plan. President Nixon today pledged his administration to a new national health plan. Good health. Feeding into the punch, Don Edwards Kennedy earlier. Good health. Feeding into the punch, President Edwards Kennedy.
I am proposing today a new national health strategy. It helps more people pay for care, but it also expands the supply of health services and makes them more efficient. It emphasizes keeping people well, not just making people well.
The President's program, as
That's
announced
okay.
today as a National Health Partnership program, I believe is really a partnership program that will provide billions of dollars to the health insurance companies. It's really a partnership between the administration and the insurance companies. It's not a partnership between the patients and the doctors in this nation.
The administration proposal would provide different plans for 4 categories of Americans. For 150 million working people and their families, employers would be required to buy health insurance providing a basic package of benefits, eventually they paying 3/4 of the premiums. For some 20 million of the working poor and their families, the current free Medicaid services would be replaced by private health insurance fully paid by the government for the poorest, with a sliding scale of contributions for families earning more than $3,000. For the 21 million aging Americans, the $5.60 monthly Medicare premium for optional doctor services would be dropped, Social Security taxes adjusted to make up the cost. For some 30 million domestic, self-employed and others, lower cost by being enabled to buy policies at group rates from insurance pools.
President Nixon today pledged his
I
administration.
think we need to play that again. So it was really almost an identical program that Richard Nixon first introduced and that the Heritage Foundation then copied in 1989. They added the individual mandate to that employer mandate that was the Nixon plan, and the individual mandate, of course, became part of the Obama plan as well. So here's my simple schematic of how the Affordable Care Act works. You notice that they've erased the single payer line there, which is a simple program. So single payer, basically you pay your taxes and government runs the insurance program for everybody and pays the bills. By the way, the Republican plan is on the right, get sick and die penniless. The Affordable Care Act actually, according to the best estimates from the National Center for Health Statistics, increased our insurance overhead by about $266 billion over 10 years if it survives 10 years. So by running this program through private insurers, it wasted an enormous amount of money. Now, we know, for instance, that Medicare runs for 2% overhead, and the private insurance plans on average run for 13% overhead. And that's some of the money that we need to actually take care of patients. This is the software that was used to implement Medicare. This is the first person who signed up for Medicare, Harry S. Truman. And Medicare was implemented 11 months after it was passed. There was no foul-up. They didn't have computers. It was basically done with cards by hand. They enrolled 19 million people in 11 months. Very simple. They sent postcards to everybody known to be over the age of 65 because they were registered with Social Security Administration and said, "Do you want Medicare?" And virtually all of them said yes. Well, at the same time we passed Medicare and Medicaid, Canada passed its single-payer national health insurance system. It's actually a provincial system because in Canada, federal government's not allowed to run the healthcare system, so it gives matching funds to the provinces to run each of the 10 provinces running their own system. But all of them have a great deal in common. You see that Canada's costs and ours were almost identical as a proportion of our gross domestic product until they implemented national health insurance. And since then, they've sharply diverged and continue to diverge more widely. They now spend about half what we do per person on medical care. The pattern of who gets care in Canada is very different than ours. So each of these bars represents 1/5 of the population, and as you go from left to right, you're going from poorer to richer. And in Canada, the poorest get the most care, which is appropriate because poorer people are almost always sicker people on average, and they need more care. And the pattern on the right is the US pattern. And there you see that the wealthiest 20%, who are by far the healthiest 20% of our population, get by far the most care in our country. And that's what our healthcare financing system results in. Canada's infant mortality rate was higher than ours before they implemented national health insurance, and very rapidly after they implemented it, it went lower than ours and has stayed there since then. Canadian doctors do okay, they're not starving, so the average Canadian doctor in 2014-15 made $337,000 Canadian dollars, but that's a reasonable income. There's a little bit less of a spread between the highest earning and lowest earning doctors in Canada than there is in the US. On average, Canadian doctors' incomes have gone up faster than the average income in Canada since their program was passed. About half of the total difference in spending in our two countries is the cost of bureaucracy in our country. Running our health insurance companies, enforcing inequality, billing. So a Canadian hospital, everybody has the same coverage and same insurance, and the province actually pays hospitals the way we pay a fire department. One check a month for their entire operation. They don't need to figure out who got each aspirin and Band-Aid. When we visited a friend many years ago at Toronto General Hospital, big 900-bed tertiary care referral center, the billing office at Toronto General was 3 people whose job was to send bills to Americans who wandered across the border, because they don't bill patients. When we got back to Boston, we went by Mass General Hospital, roughly same size, same range of services. Mass General at that time had 352 people in its billing department. Not because they were inefficient, but because that's what they had to do to collect their revenue. They're now over 1,000, I'm told. So we've had this crazy system of treating healthcare like something to be bought and sold on the market, which results in enormous excess costs. It's excess on the insurance side, it's excess on the hospital side. So every person in the United States on average is spending about $870 for hospital bureaucracy. And for doctors, it's a nightmare trying to collect our incomes. We fight with insurance companies, each with their different rules and regulations. And Canadian doctors have a simple system that they deal with. Well, if you ask Americans, what do you want in your healthcare system? Among all adults, would you favor replacing the Affordable Care Act with a federally funded system for all? 58% of Americans told the Gallup organization in May of 2016 that's what they want. Other polls find almost identical results. A recent Economist poll found 61%. So this is not an outlier by any means. I think this is more interesting. So 41% of Republicans say they would favor a federally funded health program for all Americans. 41% of Republicans. And among those who favored repeal of the ACA, at least before the discussion of the actual repeal, this is back in May of last year, majorities supported a single-payer type program. Well, we've got an ongoing debate in Washington. It says our health insurance is being replaced by a series of tweets calling us losers. That's essentially the program that's being proposed as an alternative to the ACA. It's saying let's take away $800 billion from Medicaid over the next few years and deny poor people much of the care that they can currently get. It's saying, according to the last version of the Republicans' plan, let's give some $300 billion in tax breaks to the wealthiest 2% of Americans over the next few years. And it's saying, particularly to the elderly, that you're going to have to pay much more than you're currently paying if you have private coverage. So the Republicans really have proposed an enormous step back. It's a step that the Congressional Budget Office has estimated would cost 24 million people their health insurance, would slash Medicaid spending would increase costs for the elderly and the sick very substantially, and would be a step in the wrong direction. But we do need reform of the ACA. We do need reform of our healthcare system. The question is, can we get what the majority of the American people actually want? You know, when I first went to Harvard, they told me there are two things you need to know about giving a talk. One is that an expert is anyone who comes from out of town and brings along slides. So that was even before PowerPoint days. So that's why I tend to show slides of one kind or another. And the other is that you should always end a talk with a quote from Winston Churchill. So the quote that seems relevant is that one can always rely on Americans to do the right thing after they've exhausted every other possibility. So we're well on our way to that, and let's hope that the next step is actually to do something even better than what we've done. Thanks very much. So I've surely said nothing controversial or questionable, but I'm open to opposing points of view, questions, concerns, anything you want to ask about or say as difference of opinion. Yeah.
You made very compelling points about the problems with the current system. Honestly, I'm just not versed enough in what the proposals are and how they all work to really appreciate the options. So I was wondering if I could get you to do that for me. So sort of setting aside, you know, if we assume that Republicans or those opposed to single payer do not want more people to die, and we also set aside, for the purposes of this question, corporate influence of insurance companies, what is sort of the theory, what is the ideological opposition to single payer and to sort of a different healthcare system? Where does that come from?
I think it comes from several things. One is that single payer really at base requires a substantial income redistribution. So it's a system that has to be supported by taxes, and to collect the taxes, you've got to tax wealthier people, and particularly the very wealthy more than they're now paying. And poor people who are currently paying a very large percentage of their income for health care, part of what you need is for them to pay less. They're not getting the care they need because they can't afford what they're now being asked to pay. So the poorest Americans are paying 13 times as much as a proportion of their income for care as the wealthiest. And single payer in any reasonable financing stream says we need to equalize so that people are paying similar, at least somewhat similar proportions of their income towards the healthcare system. And that means you're really saying wealthy people are going to contribute more. That's a big piece. I think a second is that there's whether it's an ideological shield for underlying interests or whether it's real, I leave for you to judge, but there's an appeal that the market is the best way to distribute goods. And that if only we allowed a real market to work, then we could have a more efficient healthcare system. And that the problem in our healthcare system today is not that people have too little insurance, but that they have too much insurance. And that they're insulated from the costs of their care, and therefore they don't behave like prudent buyers. So that we need a more market-oriented system so that patients will act like more prudent buyers, and the market will discipline hospitals and doctors and bring down their charges and costs. Now, how you actually implement that in a way that's not extraordinarily cruel, there are a lot of contortions that people go through to then try and say, well, we'll exempt, I mean, some people say, we'll exempt certain high priority items from those user fees, from the pieces that patients have to pay. So if you have diabetes, maybe we'll say your insulin, that'll be paid for. And they start to do what's called high value insurance design, where the most important things get paid for, but the things that are more on the edge or more elective, you would have to pay entirely out of pocket. So the appeal that the market is the best way to discipline a system is used very strongly in an ideological argument. You know, to my mind, that is a cover for saying poor people get less and rich people get more. Or at least that's the result. Noam Chomsky said years ago, one can't always judge what people actually mean by what they say, but you can judge what people's actual intentions are by the predictable results of what they're proposing. And I think the predictable result of that proposal is poor people get less and rich people get more. So I think that's very problematic. I think there are extraordinarily powerful interests at this point in our society that don't want a more equal distribution and don't want a discipline of the corporations that are making very great money in our healthcare system. I mean, the drug companies made $67 billion in profits last year in healthcare. That they want to hold on to that, and that's a powerful force.
So just a quick follow-up, just to clarify, the reason why that, you would say, the reason why that market logic doesn't hold up in terms of healthcare would be that you can't have winners and losers. A market requires winners and losers, but in terms of healthcare, losers are people who die.
Well, I think there are several reasons. One is that actually, I mean, if you go back to Adam Smith and market theorists, healthcare doesn't meet the criteria that economists say you need for a market to work efficiently. So you have to have symmetry of information between buyer and seller. You have to have exit from the market. You have to have the ability of the buyer to say no. You have to have entry to the market for competitors. So, you know, some of the most extreme folks in the pro-market camp say we shouldn't license doctors because that's actually a market limitation. But in fact, in the hospital sector, you know, you need hundreds of billions of dollars to come into the market and compete. So we don't have the basics for the market to function, and I would say morally we're not prepared for there to be losers. You know, at least most of us. You know, years ago there was a bank robbery in Harvard Square, and the guy was shot after he robbed the bank, and he's lying bleeding on the sidewalk in Harvard Square, and people started screaming, "Call an ambulance." I mean, the view is that bank robbers deserve health care. So, I mean, who is it that doesn't deserve health care? So, unless we're willing to tolerate that there are people who shouldn't get health care, then we can't have losers. Yeah.
So it seems to me that if we enact a fair system, which I think personally is a good idea, but it seems that there are many people who are sort of employed by these massive health insurance companies and hospital billing departments and so on, and suddenly sort of all these people are at work, which is, I mean, obviously a side effect. That what do you propose to remedy that situation?
Well, in legislation that's going to be introduced in the Senate, the proposal is 1% of the health budget, and 1% of the health budget, you know, is a lot. We spend, what, $3 trillion a year, so $30 billion a year. 1% of the health budget be devoted to a transition fund for displaced health workers, health insurance and administrative personnel. You know, we've not proposed that the health budget be cut overall. So, for instance, in a hospital, if you look at a Canadian hospital, they spend about 12% less of their budget on administration than a U.S. hospital or a Scottish hospital, which is paid the same way as a Canadian hospital. But we're not proposing that we cut the budget. What we're saying is let's give the hospitals the same budgets they currently have, but let's excuse them from that administrative work. So they would actually presumably be willing and able to hire additional clinical personnel. And a lot of those personnel probably could very effectively work with relatively modest training. not just in hospitals, but for instance in home care, we have tremendous under-resourcing of home care. And a lot of the work there is not highly skilled work. A lot of the clerical personnel who are currently working in hospitals and home care agencies and insurance companies could find employment in those kinds of things. Mental health work, again, a lot of room for relatively low-skilled personnel. So we do need to transition those folks. We need a plan for how to do that, something like the GI Bill at the end of World War II that helped people transition out of the military. And we didn't have a fund for horse shoers as the car replaced the horses. But we've displaced industries before, and basically healthcare shouldn't be a jobs industry, it should be a service industry. Yeah.
You present a lot of comparative data that makes healthcare internationally and within some single payer systems look really good. And I was hoping you could talk about the shortcomings of some of those systems.
Yeah.
So, for example, the waiting list for healthcare in England, which has the NHS single payer system, are getting increasingly long. It seems year by year, the wait times are increasing by weeks. Mental health care under NHS is abysmal. You usually get somewhere between, I think, 5 or 6 appointments before it gets suspended. Canada, the elderly are increasingly becoming worried that they won't have access to care as they get older. Vermont tried a single-payer experiment over the past couple of years, and it went so abysmally that Peter Shumlin, the Democratic governor, almost lost his re-election bid in an ocean blue state. So, what's wrong with your idea, basically?
England is actually an interesting, well, first of all, both England and Canada, of course, spend a small fraction of what we do on medical care. And we would not want to see medical care budgets cut to those levels. So Canada spends about half per person what we do. England spends about 1/3 what we do on medical care. And England has been radically privatizing its National Health Service. So we were just actually in London and had a series of meetings with some of the leaders of the anti-privatization movement, as well as the editor of The Lancet. And there's great concern that really what they're doing is contracting out the National Health Service to private firms. Richard Branson's Virgin now has $2 billion a year worth of contracts to run services in the National Health Service. So certainly that's been a major problem, but the scant budgets of the National Health Service are also very problematic. And Canada has been somewhat better. It's, I guess, the 4th or 5th highest funded healthcare system in the world, but still only half what ours is. Canada's part of its relative success is because while in Britain you can buy private insurance that duplicates the public coverage, so the wealthy buy their way out, in Canada it's illegal to buy private coverage that duplicates the public, as it is in the U.S. for Medicare. And that's meant that wealthy people are in the same system as the poor, and it's maintained the system in pretty good shape in Canada. They have waiting lists for a few high-tech services in Canada, which are longer than I would like to see, but not many. I think the other problems in Canada, they've maintained a fee-for-service system. I think there are a variety of bad ways of paying doctors. That's one of them. I personally would prefer a salaried system to a fee-for-service system. That's caused some problems in Canada, though salary also has some issues. I think, the other examples that you...
Let's think about Vermont.
Oh, Vermont. Well, Vermont was actually an interesting thing. You can find on the internet a video of me berating Richard Shumlin when he first introduced his plan at a meeting of Physicians for National Health Program. He was our keynote speaker, and I very impolitely got up and said, "You're a fraud. The program that you're actually pushing is not a single-payer program, and you're calling it single-payer. It has no chance of success." Unfortunately, I was right. And basically, the Vermont plan contemplated not a single-payer, but a multi-payer system, with replacing much of the private insurance and Medicaid program with a state program, but leaving largely Medicare and even some private insurance and the federal employees health benefit program intact. Not paying hospitals global budgets, which is what simplifies the hospital administration side and gets you most of the savings. And he opted for what's called accountable care organizations as the main structure of how to reorganize the delivery of care. And those are basically a rerun of the HMO kind of experience that we had in the 80s and 90s in this country, which were a colossal failure. And accountable care organizations, which is the new name they came up with because HMOs had gotten such a bad name, have become national policy under Obamacare as well. And that's a system which essentially is saying we're going to make providers into quasi-insurance companies where they bear risk. Here, you've got the budget and you're responsible for paying for the care of the patients who are enrolled with you. And you can keep what you don't spend on your patients. And by the way, you go into a hole if your patients are very sick and overspent. That's a way of driving small organizations and individual practices out of practice because a small practice, even a small hospital, can't possibly bear the risk of a single patient who could cost $5 million. And it's a way of saying your market clout in securing services at the lowest cost is going to be the ticket to success. So there were many defects in the Vermont plan, which unfortunately made it an unworkable one. At best, a state plan is a very difficult way to go. I mean, you've got border crossing issues, as I said to someone at dinner tonight. The second largest hospital in Vermont is in New Hampshire, Dartmouth-Hitchcock. So trying to say, well, we're going to run a Vermont program and we're going to deal with a hospital that's not even in our state. So it's a problem doing state programs. I think one can do very effective political organizing. It's very attractive. You can make progress on health policy at the state level. I don't think it's possible to do a full single payer program at the state level.
Yeah. Tom Vilsack, who is the fairly recent Secretary of Agriculture and was rumored to be in the final group to run for Vice President with Hillary Clinton, was in Albany yesterday to receive an award from his alma mater, Albany Law School. And he was on the public radio station WAMC and he was asked about health care. And he was adamant, not strident, but he was really adamant that there's three components to dealing with health care, which are access, affordability, and quality. And it is just about impossible to get all three. And he said that the Democrats, if I remember correctly, what he said, were dealing with affordability and access. The Republicans are dealing with quality and affordability. But he just said, you're not going to get the three of them. So I put that out there. I kind of know what your answer is, but I still want to put that to you, given that it came from him.
Well, we're spending $500 billion each year at this point on useless administration in our healthcare system. And if you take that money and say, we're going to actually deliver care with it, you can get access and you can get quality at a reasonable cost. I mean, so
Yeah, that seems reasonable.
the one thing you can't do, I would say there's a fourth element there, and that is corporate power. So you can't have both respect for corporate power, access, quality, and cost control.
Sound like Bernie.
Well,
That's good.
yeah, and frankly, Hillary Clinton should know better. During the Clinton administration, you're all too young to remember, she was charged with coming up with a health plan early on in her husband's administration. And Steffi Wilhammer and I, my wife is at the back, spent about 4 hours with her in her office. And at the end of that time, she said, you make a convincing case for the advantages of single payer, but can you cite any force on the face of this earth that's prepared to go up against the insurance industry and implement that kind of plan? And I said, how about the President of the United States actually leading the American people? And she said, tell me something real. You know, I think, unfortunately, she attacked Sanders despite knowing better, because she thought that that was something she could gain political advantage from. The Democrats, I think, suffered greatly from it. But we're seeing an enormous resurgence in single-payer support among the mainstream of the Democratic Party. I mean, Congressman Cooper from Tennessee, who's been one of the most right-wing Democrats and most active on health care for 2 generations, he's your
That's my
governor.
governor.
So am I right that he's not,
He is
not
a blue dog through and through.
Huh?
He's a blue dog.
Yeah, so he just signed on to HR 676, which is the single-payer bill in the House of Representatives, and proudly announced it at a town hall meeting where he was about to get hissed and booed if he didn't sign it. So there are now 104 Democrats who are official co-sponsors of the single-payer bill in the House of Representatives, which is the most in history. And we're seeing, you know, not just polls, but in the Washington Post today, a right-wing columnist, a small business columnist, who has a column saying, I thought I'd never say this, but, you know, single-payer is the only thing that can actually work for business. You know, it doesn't work for the health insurance business, it doesn't work for the drug business, but there's more healthcare than steel in an American automobile at this point. And, you know, our auto industry actually, part of why they needed a bailout is because they've got an old workforce who are expensive to pay for healthcare. And for them, it would be an enormous blessing to have a national health insurance program. It wouldn't be for Walmart. Walmart, you know, something like 30% of Walmart workers are on Medicaid. So, you know, we're paying part of the wages, in effect, of Walmart workers for Walmart. But for a lot of small businesses, a lot of corporate America that actually pays benefits, this is the way forward. So I think this is, I mean, it's a very dangerous time in our history, but actually a time when we can make enormous progress potentially as well, because frankly, some of the old ways have been discredited. The Democrats have at least begun to come to grips with that, saying the status quo is the best that can be done. That's not acceptable. That's not only can't you win elections that way, but it's not true. Yeah.
So, in keeping with some of the tones of realism that you used in that quote from Hillary Clinton, it seems like in the current political climate, it seems highly unlikely, in the absence of like a blue wave election of 18 or 20, that single payer is in the cards politically. So, what does seem to be possible is some sort of modification of the Affordable Care Act. You know, and then there was sort of the debate in the general election was, do we repeal immediately or do we try to fix it? Is it worth trying to fix some aspects of the Affordable Care Act? What are those aspects? Does that even do any sort of benefit that is even significant compared to going to single payer?
Well, the best part of the Affordable Care Act was that it actually raised taxes on wealthy people and helped use that to finance largely private insurance or Medicaid administered through private companies for poorer people. And that was a very important step. So if we raise more taxes from wealthy people and have better subsidies for poorer people under the current system, that would be a step forward. And those kinds of things would be a real improvement. Our Medicaid program, for instance, really needs improvement in a lot of parts of the country. Medicaid pays so poorly that it's hard to find a doctor. One of my former trainees spoke. We actually edited a special issue of the Lancet that came out last week on inequalities in America. And we've been running a series of conferences, one this past Monday at Harvard Medical School. And he said, you know, Medicaid pays 2/3 as much as private insurance on average. That's a message that Medicaid patients' lives are worth 2/3 as much. And that's not acceptable. So there are a lot of things that could be done within the current system that would be improvements. you know, there are relatively few of us who are asking for the whole pie. And one of the ways you get a good piece of pie is by saying, we need the whole thing. One of my friends whose father was a union organizer said her father always told her, you don't compromise before you get to the bargaining table. So ask for what you want. And once you get to the bargaining table, you may be forced to accept less. But the other thing I urge on you is, you know, politicians change. So in 1956, Lyndon Johnson wrote a letter to a constituent saying, I'm a firm believer in states' rights and oppose the mixing of the races. In 1965, Lyndon Johnson made a speech for the commencement ceremony of Howard University, in which he announced the backing of his administration for affirmative action. And he said, we seek not just equality as a theory, but equality as an outcome. You can't start a race and take one man who's been in chains for years and bring him to the start of the race, and another who's been exercising in preparation, and think that you've created a fair race. So we need a program that equalizes the outcomes in our society. Same politician. The country had changed. So, you know, yes, we need a blue wave, you know, we need all kinds of things, but we can create that. When I was in college, there were no gay people. Right? I mean, none of us knew any gay person. Of course, it turned out we knew lots of gay people. Only they were closeted. It was unacceptable to be gay. And what, 15 years ago, there was no such thing as gay marriage. And when the suit was first brought in the Massachusetts Supreme Court that challenged the gay rights, the gay marriage, anti-gay marriage laws, people said, don't do that. You're going to set our cause back. You're asking for too much. And the Massachusetts Supreme Court ruled in favor of gay marriage, and 3 years later, the whole country had gay marriage. 4 years later. So we can make enormous strides from sometimes very dark places. And they can happen quite suddenly and unexpectedly, but only if there are people who are pushing for it. And you don't know exactly where the successful push is going to come from. Rosa Parks, who refused to go to the back of the bus in Birmingham, Alabama, caused a national furor and tremendous outpouring. And she was not unique. There were thousands of, she was a well-trained advocate of civil rights who was, an organized member of the NAACP. This was not just some random person, but there were thousands more like her doing similar things. And it happened to be that hadn't caught the public imagination and attention. So I think for those of us who want things to change, not just on healthcare, but on other pieces in our society, we don't know exactly where the change will come from, but we know it can come. And we know that there can be unexpected trigger points. So it's incumbent on us to try and create those and see what we can do. I think this period is one, look, I showed you at the outset, I didn't include this slide. If you chart on a graph, the increase in death rates in counties in the United States and the proportion of Trump votes, it's the counties with the biggest increase in white working class deaths that voted by far the most for Trump. Almost a perfectly linear relationship. Those folks aren't getting anything from this administration. So you can fool people with rhetoric, but they actually see the health care that comes into their communities. Trump promised great coverage. They're not getting great coverage. They're going to know that. So that group is open for change. And really it needs to be a change that's credible and put forward views.
Yeah, I think that's all the time we have tonight for questions, but thank you so much everyone for coming in. Thank you so much.